Then you can remove the abutment, take an impression, and put an abutment, temporary abutment or final abutment if you have taken the impression before to prepare the case in advance. And this is the final result showing that, and this is very important, that the level of the gingiva on the implant is exactly the same as the one on the tooth. And the prosthodontist in this case was Dr. Alandes, who did a beautiful job with the procedural restoration, respecting what we have done by respecting the soft tissue, gingival level, and the interdental papilla. In a different case, the tooth was extracted, certainly because of infection. We were not able to put the implant, so we decided to leave the site heal by itself for about 8 weeks. That time is necessary for the gingiva to cover the alveolar socket. So we have, in that case, much more tissue to work with, and we can now raise the flap by making a crestal palatal incision with 2 releasing incisions, keeping the papillas, raise the flap, put the implant, put a bone graft, put a connective tissue graft, then close everything, wait for another 3 months or 6 months, depending on the quality of the bone, depending on the implant you had, and you have the result of the healing abutment at 3 months. Then we put the temporary crown, and you can see that on that case, the temporary crown has a level of gingiva lower than the one on the adjacent teeth. So by adding more pressure on the emergence profile on that tooth, we are able to manage the thickness and the height of the tissue in order for this level of tissue, of soft tissue, to be exactly the same as the one of the adjacent teeth. So in this case, the pink and the white aesthetic are really 10 and 10, so it's a 20. And thanks for Dr. Volley for the quality of his work. This case, we had to wait even longer than the delay type of implant placement. We had a small tooth, we had an infection. It was necessary, first of all, to extract the tooth. Unfortunately, we had lost totally the buccal plate, so even though it was possible maybe to put an implant with some stability, but it was not in a good position, so we have to do some site development by using some bone graft, by putting a membrane to do a GBR, guided bone regeneration, an O6 membrane. Then the patient was wearing a bonded bridge, which, by the way, allowed the patient to live his own life without any problem. By that time, the bone is restored, and it's time to put an implant. In that case, we are using a Nobel active implant, which gives us a fantastic stability. And if we look to the call of this implant, the call is smaller than the larger diameter of the implant. In other words, the bone has a tendency to come back again on the head of the implant. Then, after we expose the implant, we can put a temporary crown with a special design, kind of concavity, because we like not to press the tissue to make them run away. As more tissue we have, as better we feel, and we let the temporary crown for a long time. Then when we have reached the correct level, then we can do the final restoration. And again, we have an emergence profile which is concave. We have some convexity on the proximal surface to press the tissue and obtain the nice papilla. And here again, on the work done by Dr. Bicaccio for the pros and Dr. Dubichois for the surgery, we have definitely here control provisional crown, and we have, with the new shape of zirconium on the subgingival contour, we are able really to maintain the level of the gingiva on both adjacent tooth and implant side at the same level. not all the time. So you can see on this case also that on the X-ray, the level of bone stay around the neck of the implant instead of going to the first thread. Okay, so these are good point for the quality of this implant. Talking again about soft tissue, we have to talk about the way we open the tissue. We call it flap design. Flap design will vary from what we have to do. If we have to put just one implant, we can make a limited line of incision, circular on adjacent teeth, and keeping the papilla on the adjacent teeth, and making a palatal incision on the inside part of the incision. But if we expect to do some bone regeneration and some with membrane, bone graft, connective tissue graft, we need to open much more. And I give you an example here. So here these are very small incision when compared to the envelope palatal and pedicle flap with vertical incision, where we take a crestal incision from the palate, we raise from the circular incision a full thickness flap, keeping our. Here we are talking about the tissue punch. In other words, we are punching with an instrument and removing this amount of tissue. Is not so important, but for me, as a periodontist who believes in keratinized tissue, it is very painful for me to remove this tissue. So this is why I have developed what I call the pedicle punch, and I will show you that on this example. We have inserted an implant to this lady about a few years ago, and she had a crown on the second premolar, and one day she came and she was in pain on that premolars, and she was telling us that she took some antibiotic because she had the fistula, and you can see the fistula at the gingival level, between the mucogingival level and the keratinized gingiva. If you look to the X-ray, you can see that we have a crack on that root. Now, what is the choice? Should we extract that tooth like that? But I will be sure that this tooth will come in two pieces, the cornal part and then the root part, and that may destroy or jeopardize the cortical plate. What we decide to do here is to do an incision in the keratinized gingiva, following the contour of the papillas. Then we remove a little bit of bone. We were able to see the crack on the root. And then for me, it was easy just to cut that root in two, remove in one piece the apical part of the root, and then extracting the coronal part without jeopardizing anything. Then it was necessary to develop the site by putting some bone graft, not only on top of the alveolar socket, but also on the lateral side, bios and double layer of BioGuide. Then we had to wait. And already you can see that even though we do have some bone resorption, but not as much as it used to be before if we did not do this type of procedure. Now we have the choice to raise the full thickness flap or to really minimize our surgery. So what I do, I take a tissue punch and I just plug this tissue punch with force on the lingual, less force on the proximal, and no force at all on the buccal. So I am able now to raise this pedicle flap and put my implant, put my healing abutment, and by the time I put my healing abutment, the piece of pedicle flap that I have, where I have removed the epithelium, become a connective tissue graft, and I'm plugging inside this connective tissue graft by plugging and at the same time turning around my healing abutment. And then we have, without taking any tissue from the palate, making another surgery to harvest some connective tissue graft, we have bulk the tissue. we have our implant, and we have a nice contour of the buccal shape of the gingiva, even though we are not dealing with an aesthetic site. Then, a few months after, the dentist has put a temporary crown, then a final restoration. And you can see the bulk of the tissue is beautiful. We did the same thing, by the way, on the first crown, on the first molar, which explains the bulk of tissue that we have. And we did the same on the second premolars. Some parameter which has also a very important influence on the soft tissue is the three-dimensional position. What we would like when we put an implant is to obtain or to remain with 2 mm on the buccal, 1.5 to 2. I would rather have a 2 mm instead of 1.5. The more bone I leave between the implant and the adjacent teeth, the more bone I leave on the cortical plate, the better I will feel, because I will have less bone resorption. And we know today that the bone is the one helping the soft tissue to heal. So we have some rules that we have to apply, and these are some drawings that we published many years ago. They are still valuable today. In other words, minimum 2 mm between the implant and adjacent teeth, 3 between the implant, and if you go to the two central, I go from 4.5 to 4.5 between the two central, in order to have a large papilla like we will see on a case later. We do have also some measurement, not only on the horizontal but also on the vertical, to respect in order to obtain our papillas. And we know that in order to have a papilla between two teeth is 4.5 to 5, when between an implant adjacent to a tooth is 4.5, between two implant is 3.5. But when we have pontic, you can see that we can obtain higher papilla, because we don't need, the soft tissue can give us the papilla, and we don't need as much bone close to the implant to obtain that. So every time you can decrease the number of implants to put a pontic, you will have a better result on aesthetically. To understand also the difference between the soft tissue around an implant and a pontic, it is important to respect a rule defined by Dr. Vizcaya at Chapel Hill University. He said that if you have the correct level and the length of a crown, which is going to be 14 millimeters from the platform of the implant, between the abutment and the ancestral edge, we have 40 millimeters. From the gingival margin to the ancestral edge, we need 11 millimeters. The distance that we have to maintain for the soft tissue should be always 3 millimeters, like the one we have said before when we were doing the sounding. And we need to have about 2 millimeters of thickness of tissue on the buccal in order to obtain aesthetic result. Now, it is important, if you want to put your implant in a 3D, that you respect the bone and the gingiva if you put an implant and if you put a pontic. So if you put an implant, you have to have 3 millimeters from the platform of the implant to the gingival margin of the restoration. But if you have a pontic, you need to have only 1.5. In other words, if I have a ridge, by looking at the CT scan, for example, knowing where I will put my implant, following this rule, 3 or 2 millimeter, 2 millimeter of buccal thickness, 3 millimeter of coronal apical position, I will know if I put a bone graft or connective tissue graft, and etc., etc. But if I have bone, I will know how much millimeter of bone I will have to grind. Here is 3 millimeter to put the implant, where the abutment were put after. But when we have pontic, we grind only 1.5 millimeter from the crest of the margin of the restoration. And you can see the design of the gingiva. It is beautifully, it is well harmonized between teeth on the natural teeth and teeth on implant, because we have respected these biological parameters. And I say again, this work were done by Dr. Vizcaya. I am not a prosthodontist, so most of my work sometimes is finished by other dentists. A case here where instead of putting 6 implants, well, we have decided to put 4 implants and 2 pontics. And again, when you put implant, you still have to stay close to the teeth because you are sure to obtain the papillas, and then the papillas on the pontic will be obtained because it will give you the thickness of the tissue of 5 or 6 millimeter to obtain these papillas. So now the point is between the 2 central. If you leave enough distance between the 2 central, the width of the platform of the bone will give you enough vascularization to give you back the papilla. So here the teeth were extracted, 4 implants were put, 2 on the central, 2 on the canine. It was loaded immediately by a temporary bridge, and with the healing, we working with the temporary crown, we were able to develop the site of the pontic kind of concavity to give us the emergence profile of papillas between the pontic and the teeth. And if you look now the final restoration, you can see the implant. These are novel active again, and we do have nice soft tissue contouring in harmony, and now we have a bridge restoring the lateral. Maybe they are a little bit too high if I have to criticize. And this is the final work done by Laboratory Brush, Schwarz-Arad for the surgery, and Rosati Chacho for the pros. Now we arrive to the core of my lecture, which is the connective tissue graft. Connective tissue graft is something so important that it will change the biotype. As we said, in a way to preserve or augment the alveolar socket, we can work on the bone by bone grafting from the patient himself, autogenous graft, by allograft, by xenograft, and we can add on top of that some connective tissue graft. Could be from the patient himself, or it could be some allograft from the alloderm material. But one statement is very important, is that all mucogingival plastic surgery procedure applied to aesthetic implantology comes from basic periodontal surgery. In other words, you have to be a periodontist to know what you do with the soft tissue. The point is not to put the implant. Between having a surgical guide, between today, the Nobel guide and other technique, we can always put the implant. The difficulty today is how we are going to obtain a harmonized contour of the soft tissue. The purpose of doing a connective tissue graft is to preserve the site, is to secure the bone graft if you are going to put some bone graft in an alveolar socket, is to change the biotype from thin to thick, to maintain the soft tissue architecture, which is so important when you know that it's going to change. It allows you to make a flapless approach, and definitely it will enhance the soft tissue, not only on the implant but also on the adjacent teeth. Now, in an article published very recently by Dr. De Gors, he said something very important and very striking in a way, saying that acquiring an important buccal bone volume alone has with time proved to be insufficient to maintain an ideal gingival architecture. In other words, it's not because you have put a lot of bone on the site that you are going to have at the end after your restoration your gingiva in harmony with the adjacent teeth. In fact, it is recommended to systematically boost the initial gingival biotype by adding a connective tissue graft, no matter what the thickness, the quality of the soft tissue are at the beginning. So for each case, we should add connective tissue graft on the anterior zone to maintain the aesthetic result. And we have not only to increase by the soft tissue graft, but also by designing the subgingival contour of the temporary crown. And so we have a thickness which is going to be increased by the concave side of the temporary crown. And we have to wait a certain amount of time because we need to have maturation, stability of the soft tissue before taking the final impression, as already Swan and Tano have said in 2000. So there are many timing for connective tissue grafts, and we are going to go through example to show that we can use a connective tissue graft at the time of extraction, with or without implant placement. We can use connective tissue graft with bone graft, without bone graft, before implant exposition, after implant exposition, at the time of the temporary crown, at the time of the final crown, or sometime to treat some complication. This is an example of a young guy who is about 28, who had some infection, very important infection on the apex, almost to the nasal floor, a broken tooth, which explains why maybe the tissue came down, kind of forced eruption, natural one. We decided to extract that tooth to wait another week or two. Then, because of the infection, then it was planned to do a submerged connective tissue graft at the time of the site development. You can see on this slide that we have done one line to harvest the graft, so that will be a minimum trauma. Then we make a full and partial dissection on the buccal plate, and immediately, as soon as we harvest the connective tissue graft, it is important to put some sling sutures to prevent any bleeding to occur. Then, after curating again the alveolar socket, we did fill this socket with excess of bone graft. In that case, it was bios. And the connective tissue graft, which was a thick piece from the palate, was plugged partially on the buccal pouch, on top as a saddle on the alveolar socket, and plug inside the palatal flap. We had to wait for a few months, 3 months. Here are the picture at 3 months, showing that everything has healed nicely. The bone graft seems to heal nicely too. The level of the tissue is correct, maybe not in thickness, but vertically we have good tissue level. Now, when the bone was well integrated, at 6 months, we put our implant in a 3D position, being careful to keep the interproximal papilla, and we are going to roll a flap. This is the reason why we took a lot of tissue from the palate. We are removing the epithelium from the palate, and we are rolling the tissue in order to gain what we did not gain with the first surgery. And you can see after a few weeks, 6 weeks exactly, that now we have a bulk of tissue that vertically, horizontally, mesiodistally, we have all the potential of soft tissue to be managed for shape that is going to be pleasing for the final result. We take the opportunity to make this case with a fantastic lab technician, Mr. Jean-Marc Etienne, who is going to send us, after doing the wax up and changing everything to zirconium, we receive the zirconium abutment on which will be the final crown, and we receive the temporary crown. And you can see on the temporary crown that we have a concave shape, subgingival concave shape. We try on our implant the zirconium abutment. You can see the implant in the correct position. The fitting of the zirconium abutment is perfect. But when we put this zirconium abutment on the implant in the mouth, we can see some bleaching. And this bleaching goes more for 5 minutes. In other words, we are applying too much pressure for that tissue. So in that case, we remove that abutment, which was just for try, and we start working on the temporary crown. The temporary crown had the same shape like the zirconium abutment. This is why when we put the temporary crown at day 0, we have the same bleaching. So it was necessary now to decrease the pressure from the subgingival part of the temporary crown to decrease the bleaching and allow this tissue to come down, and then things will happen. And I'm finishing this case in the next few weeks in Paris, and it's going to be a beautiful result. Here we have a case of a connective tissue placed in a tunneling at the time of extraction and at the time of immediate implant placement. This is a flapless approach. We put the implant in a correct position. You can see the amount of connective tissue that we take. It goes not only on the extraction side but also on the adjacent teeth to reinforce the thickness of the papillas. The implant is in the correct position, and this is about 1 week after finishing, after suturing the connective tissue graft in the pouch. Then we let the tissue heal, and it's time to work on the temporary crown by increasing maybe the mesiodistal diameter, by decreasing the convexity of the submergence convexity. And you can see that we have increased not only by the connective tissue graft but by the work we do on the submergence profile of this crown. We are able on the final restoration to have a nice bulk of tissue, beautiful papillas and beautiful convexity, beautiful harmonious tissue around this implant restoration done, by the way, by Dr. de Gors. Now we have another possibility where it was not possible to make a submerged pouch, but we had to do a flap elevation because under the site of the implant where we were supposed to put the implant, there were a root that it was necessary to remove to clean the socket. So we make a limited flap, by the way. We use the osteotomy to be in a good direction, mesiodistally, to increase also the size for the implant. We had a lot of bone mesiodistally. We put an ankylos, and then by harvesting a nice piece of tissue graft, we put this connective tissue graft, we suture it, we stabilize it with 2 mesio and distal sutures, pulling up this connective tissue graft, and then Dr. Pinto will do the temporary crown and the final restoration. And because of this changing of biotype, we are able to end up having a nice harmonious contour between the adjacent teeth. The level of the gingiva on the lateral is below the one of the central and the canine. So it is harmonious